push. The older ones, you used to have to put a drip in the arm and run them in over an hour and a half, whereas now you just take a syringe and go like that. We recommend actually there's one which is what we call a double bolus, and one's a single bolus. And they're both, they're easy to give, much easier, particularly in a country situation, don't tie up nursing staff, and you know it's in. One of the issues used to be that in the smaller places, particularly where they weren't used, they'd run out, you know, so the expiry date would come through. We now have a system of rotating them through the bigger hospitals so that that happens. So I can't say all country hospitals have access to them, but I think a significant number now do, and I know that the country hospitals, the Rural Doctors Association, are pushing strongly that everyone does. And in fact, one of the purposes of these guidelines was to support that push.
What are the questions? What are the questions you get? What are the criticisms or things that you most often get from doctors either in the city or the country?
Well, one of the major changes in cardiology has been the use of what we call invasive procedures. So that's taking pictures of the arteries of the heart to see if there's a blockage there and then going on and dealing with it. Now, 10 years ago, we didn't do that routinely after a heart attack necessarily, only in patients who had symptoms. What has changed now for both these group of patients with non-STEMI and STEMI is that we would recommend that they have a coronary angiogram either during their admission to hospital or soon thereafter. Now that's a major change, and many of the doctors, particularly the older doctors who have a view of an angiogram as a very dangerous procedure, ask, you know, do we really need to send the patients to town to have this? Is it really going to be of benefit? What's the data to support that? And luckily we have extremely good data now to show that people who particularly actually have a non-STEMI do much better if they come down and have a coronary angiogram, and if they do that, about 50% of them will end up having a coronary angioplasty, about 10 to 15% will end up having a bypass operation, and the remaining 25 to 30% will remain on drug therapy. But there's clearly benefit both in terms of lives saved, further heart attacks, and very importantly, and this is actually the biggest saving, recurrent admissions to hospital, because you deal with the problem and it's fixed. So that's the really major change in these guidelines compared to a few years ago, and that's what most people ask, as I say, particularly from the country, do I really need to send the patient down? Because obviously it's traumatic for them. The other area of major change which we get asked a lot about is troponin testing. Now, troponin is a chemical in the blood. It's said to be uniquely from the heart. So if your troponin is elevated, there's been some issue with your heart. And we now use this as a very sensitive test to assess whether your chest pain is from your heart or from something else. But there are a number of occasions when troponin can be elevated when it's not actually due to a heart attack. It may still be due to a serious problem, such as a clot in the lung. It may be because your kidneys aren't working so well. Sometimes it's a funny thing about the test. So many questions around troponin, and I guess it's a subject in itself. But in essence, we use that very much to triage people in the big hospital. If they come in and the troponin's positive, they go to coronary care and they're treated like a heart attack. If they're negative, they go another area and they're assessed by having an exercise test to see if they've got a heart problem. What we have done is really postpone death from heart disease by 2 to 3 decades, I would say, with our treatments. If you go back to the mid-1960s or 70s and you look at the death rates under the age of 65, they have been more than halved over that period of time by various means, by our better awareness of risk factors, but importantly, and we've got good evidence now from Perth, by our treatments. So by treating people, particularly with bypass surgery, somewhat lesser extent with angioplasty, but now with very powerful drugs, we're extending people's lives by literally decades, which is different to other areas of medicine. So you certainly get a good long-term result. If you have a bypass operation, the bypass grafts themselves have a longevity. There's 2 sorts of grafts. There's vein grafts and there's arterial grafts. The arterial grafts seem to last, once you get through the first few months, very rare for them to block off at all, in fact, but certainly 20 years plus. The vein grafts, the median is around 15 years, so obviously you do lose some of those. In terms of atherosclerosis, the underlying process which most the people in our population have. We now see, well, just recently been shown that if you lower your cholesterol enough, you can actually reverse the process. That's the first time that was shown. That was presented at an American meeting in March. So I now recommend mostly to people who've got heart disease that their cholesterol should certainly be under 2. LDL cholesterol should be under 2. It seems that that if you could, it's almost a straight line. They used to think that there was a critical level of cholesterol where things would take off, but in fact it's a straight line. So the lower your cholesterol, the less your risk of heart disease.
It's not hard to look around and see people who look as though they're on their last legs. That not much you can do for them. And we imagine that people will eventually see it in us. What happens when you see it, that someone's actually reached the limit?
Well, at some point in time, despite all the treatments you've got, you can't do anything more. And at that point in time, hopefully the patient and their relatives and you realise it and you come to an agreement about where you're going. What actually usually these days reaches that point is what we call heart failure. So as I've said earlier, the heart's a pump and the muscle has to pump. And if the muscle stops pumping because it's damaged by having multiple heart attacks or other mechanisms, eventually it just can't push enough blood around the system. And although we've got powerful drugs to help, we've now got devices, clever pacemakers that help. When you're in that situation, the only thing that will cure you completely is a heart transplant. Now, if you're young and fit, then you may be a candidate for a heart transplant. But most of the patients we see are actually 80 plus, and there's no question of a transplant. And once they reach the point where the heart just can't pump, then it's a very uncomfortable situation, and eventually they will die. And in fact, heart failure is a more fatal disease than many cancers. The people think of cancer as very fatal, but once you develop heart failure, your chance of surviving 2 or 3 or 4 years is actually quite low. And that's why all our treatments are aimed at preventing the development of heart failure, because once you've got it, not much you can do about it. So the reason we treat a heart attack so aggressively is to limit the amount of damage to the heart. If you damage 5% of your heart, you're going to be much better off than if you damage 10 or 20 or 30 or 40. Once you reach that end stage, at the current time, there isn't much to do. You may have seen a thing recently on that they were cloning people's own cells on the TV last week. There's always been the hope of artificial hearts. They've not really got into practice yet, and then maybe animal hearts, but it's probably going to be a race between the artificial devices and cloning your own cells. Probably not going to be in time for any of us, though, I don't think. Maybe our children.
So if you want to stay alive until you're 100, or at least make your heart work until you're 100,
Yeah.
so you've got to get your cholesterol right down.
Cholesterol right down. Blood pressure down, low. Same as cholesterol now. It's clear that we used to think, there was a magic number where you got there and suddenly there was a threshold at which things got bad, but in fact it's the lower your blood pressure, the better.
And what should that be?
As low as you can get it without falling over.
Really?
That's what it should be. So, but traditionally we talk 120 on 80, 130 on 80. The guidelines now recommend 140 on 80 or 130 on 80 if you're diabetic, because you've got a higher risk.
And how much exercise?
Well, the Heart Foundation recommends that you should exercise most days of the week, so that's 4 I guess, for at least 30 minutes. And it's important that you do the time. Many of the patients will say, well, I walked around the block the first time it took me 30 minutes, but now I can do it in 15, isn't that wonderful? But you're not getting any benefit from walking for 15 minutes. So you need to walk for 30 minutes. You need to exercise at a level where you're puffing but can still talk. So not a gentle stroll looking in the shop window, but not running so fast that you can't, that your heart rate goes too high, particularly when you're getting over 50 because your knees give out, or if you push it too hard.